Hello, everyone, and welcome back to the Outcomes Rocket. So excited you tuned in again because today I have the privilege of hosting Steve Coen on the podcast. He is the CEO and co-founder of SaRA Health. They're a digital health platform that helps providers deliver remote care and get reimbursed with less friction. We all want that. Steve, glad you guys are in business and welcome to the podcast.
Thank you very much for having me, Saul. I'm excited.
Likewise, Stephen. Folks, Stephen and I coincided in some of the Ortho Forum meetings, and so excited to dig in with them. Stephen, talk to us about you and what inspires your work in healthcare.
I'm a frustrated patient. I've had labrum surgery, ACL meniscus repair, had a lot of physical therapy. I'm currently basically in a maintenance float program because I still compete nationally as an Olympic weightlifter. So it's not if I have PT of the year, it's when and how much. I think it is. There are women in China that are warming up with my max, but that's okay. I'm strong for me. I'm stronger than I was yesterday. And that's the point. But yeah, frustrated patient who just didn't understand why there was that black hole feeling and that lack of connectivity in between visits, especially for physical therapy. And so went out to go change it. We started the company in 2018. Technically, we started working on it in 2016. So we're almost a decade in. And we have been solving the same problem the entire time. Just before these remote therapeutic monitoring codes came out, we were helping physical therapy groups that were on site at employers be able to scale their impact by engaging with patients using our system without having to increase their people. The remote therapeutic monitoring codes, it's basically that. Like, that's it. So we like to joke that we're doing RTM before it was cool. And yeah, pivoted there in March of 2022. And since then, I've served over 80,000 patients, hundreds of practices, more than that, and clinicians. And yeah, getting close to 100,000 patients, which will be a pretty fun day to hit, hopefully here in the next few months. And yeah, that's a little bit about us.
I love it, man. I see it in the horizon, over 1 billion served. I see it. Look, man, thanks for sharing your story. Definitely interesting to see how the market evolves, right? And you guys were doing remote therapy before the reimbursement codes even existed. So you built this infrastructure, you're helping employers, but then boom, these codes come in. Like, how are things looking now? And by way of that, help us understand how you're adding value to healthcare organizations.
Absolutely. So we work with musculoskeletal providers, so primarily physical therapy groups, pain management, and orthopedics, and a little bit of speech now. And actually that's growing, which is pretty exciting. What the platform does is it uses AI to send a text message, so SMS text, no app to download, no website to go to, that asks a question that can be answered in one character or one word. It is as close to what that clinician would ask if they had 100 hours in the day, that our typical response rate is somewhere in the realm of like 40 to 45% on a daily basis. So almost every other day, patients are responding to those questions. What we're seeing from an outcome standpoint is patients on SaRA get to a better functional outcome. So we've got one internal study that showed that they are less likely to drop out of care by, in some cases, 50 and 60% less likely. And then financially, today, we're typically seeing practices drive an extra, for physical therapy in particular, an extra, call it like $50 to $60 in revenue per patient. As a result, in 2026, and getting a little bit ahead, but I think that's okay. In 2026, there are new codes that are going to get released that are going to basically double or triple that as a result of our model. And what we just analyze it like, okay, if this new code existed today, what would have happened over the last 3 months? It was like 2 to 3x, like perfect. That's it. So we're very excited to see that finalized fee schedule come out, hopefully in the next couple of weeks here in mid-November. Hopefully the shutdown doesn't hurt that. I have no idea. We'll do it. It's out of our hands.
Yeah. I was doing a webinar the other day and a couple doctors are like, all right, over under pre or post Thanksgiving, does it stop? We had a lot of pre-Thanksgiving because the idea is people are going to have to travel and stuff like that. So the government's not going to want to mess that up.
I think it's pre-Thanksgiving too. A group of our friends just sent out a text and we're rounding up some additional food and household items to be able to fill the gap in the SNAP and the WIP programs. And so enough of that. Getting back is just like, I think the frustration is going to hit a point of no return sooner than later.
Yeah, no, I totally agree with that, man. No, well, listen, super cool. And these codes are changing because people want care in the home. We want our care like we want Amazon. We don't want to go to the doctor's office. We want to do our blood draws from the comfort of our own home. We want to do our physical therapy at home if possible. We want to eat our home cooking instead of being at a hospital, right? And so you guys were way ahead of the game and now you're benefiting from it. What would you say you do different or better than anyone else out there currently in the space?
I'd say most of the folks that are out there that I don't see as truly competition, like the competition is the 85% of practices who haven't adopted some sort of remote strategy. Like that's the competition
Status
versus the status quo versus the other companies there. But most other companies facilitate these codes via a home exercise program. And what we found is we started with that. We're like, hey, we'll just make the home exercise program better. But what we found is a lot of the feedback on the patient side was, I know what my exercises are. I just want a reminder and a way to talk to my therapist in between visits. Like, oh, then that's a great use case for SMS, which is much lower friction, but you still do need to be a software as a medical device. So we went to the FDA and said, hey, here's our functionality. Here's the whole thing laid out. We believe it's software as a medical device functionality based on these two things. And they agreed. So basically they said our algorithm is the software as a medical device versus the prescription of video-based home exercises, which gives us a lot of flexibility in the medium. Like technically we could do it via smoke signals as long as we knew the smoke signal was received by the patient. It's a little tougher. Apps are pretty tough to get people to download, especially for plans of care that are likely to be less than 3 months. And so we find the text message, it feels like the PT is texting the patient each day, right? That's the feel of it. And so it's very much a relationship focus versus a pure adherence. Not that we don't ask about, that is very important, but instead of being like, we think the more valuable data is not, did you do 5 sets of 5 or 3 sets of 5? It's, did you do your home program at all? And does it actually fit for you? Is it too long, too short, just right? Are you having pain in areas of your daily life? That is, we think, much more valuable data, and we can get that more reliably than the home exercise piece.
That's great, man. And by the way, I want to go back to something you said to make sure I understood it right. So you said that the question that come in, you request a 1-word answer?
1 character or 1 word.
Oh, so it could be an emoji?
We don't have any that request an emoji because we do have enough of our patients that are on like track phones, flip phones, etc., that don't have emojis. But yes, you could reply with an emoji. So I think there's probably a question on like, how are you feeling about your adult daily living, like your daily living activities today? Probably like responding with a confidence level of 0 to 10. And you could send back the arm emoji. That would actually be a pretty darn valuable data point to get.
All right,
so
I just didn't know. Like, I wasn't messing with you, more so like, okay, I guess it is an option, but 1 character essentially means a number.
Yep.
Or a word.
Yep.
Okay, got it. Super cool. And so there's probably a method to the system there. When you guys made that shift to 1 character, did it increase response rate?
It did. It did. What we found is it actually does 2 things. It lowers the cognitive load on the patient because now there's not this nebulous like, hey, how are you doing today? Or, hey, how are your exercises, right? Like that's very nebulous and can be difficult to even formulate the response. And so by pushing towards a specific set of answers, we find it lowers the cognitive load on the patient, which increases response rate. We also found that it lowered the likelihood of novels coming back to the clinicians. And so whenever we see folks out there like, oh, like we text to and kind of like taking like little shots at us and like show an example of one of their questions, we're like, oh, we asked that 7 years ago. I know what's going to happen with that. Like, you don't want to do that, but I'm not going to tell you. So that's, yeah.
That's awesome. No, thanks for sharing a little bit more on that. These fine points, I think, separate you guys from others that are out there maybe just starting in the space. You guys have this really cool history of chatting with patients, messaging, fine-tuning. Now you get to add billing codes and tech to it and your next level. So what has been your biggest setback as an entrepreneur and a key learning that you learned from that?
I think when we transitioned to the fee-for-service world, we had a too naive assumption that if the payer covers and the practice submits the bill or the claim, that it will get paid at a high rate, at high percentage. And that was wrong. Though we had established our business model around that, it actually still is established around that. And so that was a pretty big setback to realize that we had groups that were billing United, which has it in their payer policy. If you go to their medical policy, it says these codes are covered, and we still had these groups facing denials. And we're like, what in the world is going on? And so what we found is like, these are just these codes are different, right? They're different than your treatment codes. They're different, and that has pros and cons to it. And so it actually led us to build what I think is going to be an even further differentiator as we actually built an in-house billing team for the codes we facilitate. So it can go complete soup to nuts. If you enroll patients, if you engage with them, like basically do what you're doing today, use our platform instead. It's going to be way more efficient than try to respond to some patient emails. Like in the same time, you can respond to 2 patients via email. You get through 20 to 50 in our platform. We're tracking it all. And then you just click sign note. We will bill it for you. We will make sure you get paid. You'll get paid like any other code. It'll get dropped into your account. And then we'll say, okay, you got paid for this many. Here's how much you owe us. Do you want to play this game again next month?
Yep. No, I think that's really great, man. Big setback led to new product features and value that now take the RCM component and really free the clinician from it and let them do what they're best at.
That's it.
That's awesome, man. Yeah, and curious about that, right? Because I was thinking that with the price point of these therapies, right, not being on the higher side, is there still a prior authorization deal that has to happen there?
Oh, there's a whole... Yeah. And that's what we learned is
shocking.
These internal and external billing groups have gotten really good at that prior auth. Like a lot of those things they're really good at. That is the core. They're way better than we'll ever be. And those problems really don't like exist when it finally comes time for us to bill our codes. Like a lot of that stuff has been taken care of by that point because we're not billing codes till 30 days after the eval at the earliest. And so with that, like a lot of that stuff has been taken care of, but then it's also, again, goes back to they're so different. If you have a team that's built and even AI built on prior auth outcome, like a prior auth, making sure that the correct info is going to the clearinghouse, right? All that, this is just so different. You're like, wait, what is this denial code? I don't know what that is. Like, oh, it's only like a $20 code. Like, forget about it. There was actually, to put it in really fine perspective, a customer we worked with came from a large health system that did remote patient monitoring. So the kind of precedent codes to RTM for 3 years and didn't bill a single of the codes that they facilitated because the rev cycle was just like, nah, it's not worth it. And plus your project's in the green because of the reduction in readmission penalties. So like, you don't need this to justify your existence. So we're just not going to take on the extra work.
That's mind-boggling, man. Anyway, that's an issue for another day, but definitely a big problem. And so many providers get whacked with prior auth. So that's why there's a lot of companies out there looking to solve it. It's a technology problem. Like technology could take care of this. Awesome. Steven, and don't say AI to this question, please. What is one healthcare tech or trend that will change healthcare as we know it?
I'm biased, but I do think the proliferation of non-fee-for-service models is going to continue to change healthcare for the better, right? Now, I'm biased because we were in that world, saw what fee-for-service can do when they adopt something similar, right? Like that it was basically like the same value proposition that we were selling to these PTs that were direct to employer is the same value proposition in many ways, just slightly like fine-tuned, right? And so as you see more of these cash pay, these subscription-based models that continue to proliferate in the non-fee-for-service world, I think that's just going to continue to give different evidence and examples of how fee-for-service can catch up. And so I think it's actually the experimentation in those areas and even getting creative within a compliant way within the Medicare rules around group fitness, around group therapy, whether that be mental or physical. Like, I think that like those new models that are coming out, like you look at the guide model, Path, and others where you're seeing some groups get really innovative, whether in the fee-for-service world or outside of it. And I actually think that is going to help drive more good into the whole system. Because if you're like, we can't do it that way because we can't go full cash base like that. But like we can get close with this and like establish this delivery model where we now take this PT and they become this mission control. And so instead of seeing 10 patients a day, they're seeing 9, and an hour slot each day is just managing our remote care program. So you're seeing some of those ideas coming back and forth. And so I wasn't going to use AI anyway, but I think that using different models that are proliferating and using that as basically like idea food, like brain food of how we could adapt to this in a fee-for-service world and be able to take those best practices, adapt them, copy paste with formatting to be able to serve our patients better.
No, that's great, Steven. I actually agree, man. I feel like there's big promise. We're starting to see progress in some of these programs like you shared, and the government tends to lead the charge, right? And we saw a lot of that with Medicare Advantage, with the direct contract, now ACO REACH program, and now payers are starting to do it. I agree with you, brother. I feel like the future's bright there, and I'm hopeful that we'll be able to use our healthcare dollars a lot smarter with companies like SaRA Health. So with that said, man, take us home with a closing thought and the best place the listeners could reach out to you and your company to learn more.
Yeah, I'd say if you listen to this and you want especially a provider group or work with provider groups that values that relationship between your patients and providers, let me know. That's what we're here to do. We're here to help figure all that out by showing value across the quadrant, right? Your patients see value, your provider sees value, your practice sees increased financial value that funds the whole thing, and payers are seeing value, or else there wouldn't be CPT codes. So you've got that check, right? And so that's my parting thought is the relationships matter. Come talk to us. And my email is Steven, Steven at SaRAHealth.com. Check out our website at SaRAHealth.com as well. We're active on the socials, but LinkedIn definitely the most. And yeah, feel free to reach out. I'm more than happy to have a chat and see if there's any way we can help you. And if it's not us, I hope you find success somewhere else in your remote care journey.
That's awesome, Steven. Really appreciate that. And folks, in the show notes, you'll find all the ways to get in touch with SaRA Health. That's SaRA without an H. You'll see it inside of the show notes. It's SaRAHealth.com. Right, Steven?
It is. And do you mind if I say why it's called that? So it's an acronym. It stands for the Strength and Resilience Assistant. So we're creating stronger, more resilient patients and practices.
Boom. Love that. Strength and Resilience Assistant. Fantastic. Coming from an Olympic weight trainer himself.
Not Olympic level, just the sport. Not Olympic level, just the sport.
All right. Well, it was more fun to say that. But yeah, all right. Thanks for level setting. Folks, just a pleasure to have Steven on the podcast from SaRA Health. Thank you all for tuning in. And Steven, thanks for joining us. That was fun.
Thank you very much.